Welcome to this session of women's health, and in today's session, we're going to be looking at an important obstetric emergency called shoulder dystocia. So, shoulder dystocia is simply the failure of the fetal shoulders to deliver spontaneously after the head has emerged. It's an important obstetric emergency because it leads to a risk of maternal and neonatal morbidity. So when it comes to the epidemiology, it occurs in about 0.2 to 3% of vaginal deliveries, and it's of high incidence in macrosomial and maternal diabetes, and also prolonged second stage of labor. Okay, so when we're asked to name the risk factors for shoulder dystocia, we need to classify them into maternal, labor related. So when it comes to the maternal, we've got a known history of diabetes or a new onset of gestational diabetes. We've got obesity. We've got previous shoulder dystocia. We've got a short stature. We've got excessive weight gain. Okay, when it comes to the fetal complications, we've got macrosomia, which is simply a big baby greater than 4 kg, and also male sex and postpartum pregnancy, and also abnormal presentation. When it comes to labor-related risk factors, we've got prolonged second stage of labor, instrumental delivery, induction or augmentation of labor. Okay, so when we're talking about induction or augmentation of labor, we need to first perform, that's why we perform a scan before inducing these patients, because we don't want something like shoulder dystocia to take place. Okay, so we need to know the size of the baby. If it's a big baby, we opt to take for Caesar immediately, and we do not think of induction. So the mechanism of shoulder dystocia is simply the anterior shoulder is impacted against the pubic synthesis. So the head is delivered, but the anterior shoulder is impacted. So we need to know certain maneuvers or what we're going to do for this patient so that we prevent maternal morbidity or neonatal morbidity. When it comes to the pathophysiology, after the fetal head delivers, okay, the anterior shoulder becomes impacted behind the maternal synthesis pubis. So obstruction prevents normal delivery of the fetal head. So there's risk of brachial plexus injury, hypoxia, and a clavicular fracture due to the invasiveness of the maneuvers which we can do in this situation. So when it comes to risk factors, we've got a Tato sign. So the fetal head retracts against the perineum after delivery, and there's delay in the descent of the shoulders despite maternal pushing. So failure to deliver the body within 60 seconds of head delivery, we need to call for help and manage it as shoulder dystocia. So this condition can cause maternal anxiety, it can put the mother in distress, and can cause a lot of pain. So to understand this topic or the management, we need to first understand what maneuvers we can do for our patients. Okay, so the first maneuver we think of doing is the McRoberts maneuver, which is just simply flexion of the legs onto the abdomen, which causes rotation of the pelvis and alignment of the sacrum and opening of the birth canal, and it also causes suprapubic pressure, which is applied to the fetal anterior shoulder. Okay, so we apply suprapubic pressure to the fetal anterior shoulder, and it will help us have a normal delivery because we are going to dislodge the shoulder. So this is just what we're talking about there. So the other maneuver is a Wood's screw maneuver, or the Wood's corkscrew maneuver, which is just a technique where we are going to rotate the baby shoulders within the birth canal using a rotation or a corkscrew like motion. Okay, so with this maneuver, we're just aiming to dislodge the impacted shoulder to facilitate delivery. Okay, so the Wood's corkscrew maneuver is we just insert 2 fingers into the posterior vagina, and also the posterior shoulder is rotated to the anterior position. about 180 degrees by corkscrew movement. So with that being said, we've got a Robin 1 maneuver, which is an external maneuver. So with this maneuver, the technique we're going to use, we're going to apply suprapubic pressure with the heel of the hand or the fist. Okay, we're going to push the anterior shoulder downwards and laterally, and we're going to be rotating it from the anterior posterior to the oblique diameter of the pelvis. Okay, so we're doing this to reduce the biacromial diameter, so which is just the distance between the baby's shoulders. Okay, so our goal is just to prevent shoulder dystocia by this external maneuver. We also have an internal maneuver, which is the Robin 2 maneuver, which combines both suprapubic pressure with us also inserting our fingers into the vagina posterior to rotate the anterior shoulder of the baby. Okay, so it's just think of it as we are doing both uh, the McRoberts maneuver and also the Woods corkscrew maneuver. That's a Robin 2 maneuver. Okay. So another thing of maneuver of thought is a Gaskin maneuver, which is just also known as the O4 maneuver. So the O4's maneuver is simply by repositioning the mother to allow widening of the pelvis. So in this situation, we are allowing the mother to have their knees on the ground and their hands on the ground, so that we just widen the pelvis and allow the baby shoulders to dislodge. Okay, as of last resort, we have got the Zavanelli maneuver, which is simply pushing back the fetal head into the birth canal to allow or to take the patient for an emergency cesarean section. So with that being said, just a summary of all the maneuvers. We've got the Zavanelli maneuver, we've got the suprapubic maneuver, or the suprapubic pressure, where we are doing the McRoberts maneuver by telling the mother to put their legs on the abdomen, and also a Robbins maneuver and the Woods corkscrew maneuver. When it comes to the management of shoulder dystocia, the first principle is to call for help. We're going to call the obstetric staff, neonatal team, and also the nurses on board and the midwives. So we're going to document the time and events, and we're going to position the mother and perform a McRoberts maneuver, which is just the hip flexion and abduction. We're going to apply suprapubic pressure to dislodge the anterior shoulder. If this fails, we're going to ensue our secondary maneuvers. Okay, our secondary maneuvers, we're going to perform an episiotomy to facilitate these maneuvers. We're going to start with the internal maneuvers. So we're going to do a Woods corkscrew maneuver. Okay, just rotating the posterior shoulder, and we can also perform a Robin 2 maneuver. We're going to combine a Woods corkscrew maneuver and also perform also apply suprapubic pressure in a wood in a Robbins 2 maneuver, which is an internal maneuver as well. Then we can move to the external maneuver, such as the Robin 1 maneuver, where we're going to apply pressure on the posterior aspect of the anterior shoulder using the heel of our hand or fist. Okay, so with that being said, our aim of doing all these maneuvers is just to deliver the posterior arm or and reduce the shoulder width. So if all these maneuvers fail, we can now move to the all fours maneuver, which is the Gaskins maneuver, if it's feasible, and which involves just allowing the mother to reposition herself onto the ground with her knees and her hands touching the ground. Okay. With that being said, if all these maneuvers are not helping, we are going to move on to the Zavanelli maneuver, which is just pushing back the fetal head and preparing for emergency cesarean section. And also, these are just last resort maneuvers, and we can also perform a clavicular fracture intentionally to reduce the shoulder width. So this is not a common practice, and it's very rare. Okay, so with that being said, we can look at just a simple mnemonic which can help us remember all these maneuvers. The mnemonic we're going to be using is helper. So we're going to call for help. We're going to evaluate and explain the clinical situation. We're going to perform our Macroberts maneuver. We're going to apply suprapubic pressure. We're going to enter the birth canal posteriorly and access the need for episiotomy. We're going to remove the posterior arm. Okay, we're going to perform our rotational maneuver such as the corkscrew maneuver, Wood's corkscrew maneuver. We're going to roll the patient to the hands and the knees, which is the Gaskins maneuver, and also if all this fails, we can also look up to the Zavanelli maneuver. So when it comes to the complications of shoulder dystocia, we can classify them into maternal and fetal complications. So when it comes to the maternal complications, we've got perineal tears and vaginal tears due to the invasiveness of this procedure. Remember, we can perform an episiotomy when you're doing those maneuvers. We've got postpartum hemorrhage. We've got symphysial separation. We've got psychological trauma due to the distress that this procedure comes with. We've got fetal and neonatal complications such as brachial plexus injury, Erb's palsy and Klumpke's palsy, clavicular or humeral fracture. We've got hypoxic ischemic encephalopathy if prolonged, and death in severe cases. So prevention of shoulder dystocia is we need to identify high risk mothers such as macrosomial babies, which are just babies greater than 4 kg, and diabetes. Patients who come in with diabetes, we need to be aware of the risk of shoulder dystocia and the previous history of shoulder dystocia. We need to plan for operative delivery if indicated. We need to avoid excessive traction on the fetal head, and we need to do adequate intrapartum monitoring. So with that being said, this was just a short session on shoulder dystocia, and hope we've understood one or two things. Thank you for watching. Stay blessed.